Good afternoon. It is June the 18th. Getting into the dog days of summer, 3 days away from the longest day when summer, I think, officially starts, although I can never quite tell when summer starts these days. And we're all still semi-locked down, although some parts of the country are opening up in quarantine. And it's another time for THCB Gang. I am Matthew Holt, founder and publisher of THCB at Baltimore on Twitter, and your host. And I have a great lineup today. Got some regulars, and finally at last we've got rid of all. We're getting rid of all the old men like me and promoting more women on the gang, which is not before time. So who are the regulars? Well, the old men: Kim Bellard from the wilds of Cincinnati, Ian Morrison from Menlo Park. We'll be joined today by guests who are becoming regulars: Maggi Cary from DC. And Lygeia Riccardi, also from DC. And we have new guests today, Kistein Monkhouse and Medell Briggs. I will introduce them a little bit more, but let's get going with the gang now. All right, how is everybody? Hey. Looking alive and kicking. Medell clearly lives in a much nicer house than the rest of us. Or maybe she's just chosen that background. That's pretty convincing. It reminds me of you may have seen some of the Formula One racing if you've been flipping channels late at night to replace the real Formula Ones. And I can't tell the difference between the cars and the regular cars. Anyway, maybe that's just me. All right, so let's go around the horn. And I want to. It's been another just crazy week. We still have, coronavirus heading back up, as many people talked about the last couple of weeks. We have still going on protests around Black Lives Matter and much, much more. And then we have, the rest of healthcare doing what the rest of healthcare does. So let's just go around and start and give me a comment about what you've seen in the last week or so. Ian.
So much. We had a Martin Luther King board meeting this week, and I could maybe update you on some of the thoughts of that. Medell and I worked together on that organization. But I guess the last time I saw you, Matthew, I was obsessing about Rhode Island, and I continue to track the open table database, and Rhode Island is the one that is bouncing back more than ever. So I'm worried a bit about Rhode Island having a test spike, but it could be the hotspot given the rapid recovery. And the other hotspots obviously are prisons, long-term care homes, choirs, and large gatherings for political purposes indoors.
I can't imagine what you mean by that last one. Yeah. Anyway, all right. Maggie, what have you seen the last week or so that struck your fancy?
Well, interesting. An article came out in the Wall Street Journal about, what should be done. And then there was another piece, and it's a matter of more and more, it's a matter of, as we know, dose and time. And I'm going to go with Ian, which is the hot spots are large political and other rallies indoors. And it's interesting when I walk several miles a day, and some people seem to think that not wearing a mask is a political statement.
Many people think that, I believe.
Even in DC.
Even in DC. Lygeia, you're in DC. What are you seeing in terms of the politics of DC, or anything else for that matter?
When I go walking, I often bump into, if not deliberately join, a Black Lives Matter protest, because they're kind of almost everyday occurrences. I don't live very far from the Supreme Court, so that was the latest. In terms of I would say in general in DC, at least in my neighborhood, across the town from you, Maggie, people wear masks more than not. And if anything, there's pressure to wear a mask. I've certainly heard from people in other parts of the country where they get criticism for wearing a mask, which it's all over the map. But most people seem to be wearing masks a lot of the time here where I am, including in the protests.
Most of them, same here. It's just the ones that don't stick out.
Fantastic. Medell, you're in LA. Tell us a bit about what you're seeing.
Gosh, these past couple of weeks have been, of course, incredibly busy. And one of the things that's really on the top of my mind is that the intersection between, of course, all of the various different COVID disparities, but also our concern on the front line of COVID increases in rates. I'm a practicing emergency physician. And so we're now at this point of how do we move forward with healthcare operations in this new COVID era, and all the various different changes that we need to do in terms of our healthcare institutions, our communities, but also where does technology play a piece? And then also we're, of course, in this social movement right now. And the social movement actually highlights so much of the systemic racism and bias that we see, of course, within the community, socioeconomic reasons, police brutality, but we see those same things, of course, in healthcare. So at the top of my mind right now is how do we transform our words into actions and make sure that there's justice throughout all industries?
No, that's a deep point. I think we have to come back to that in a second. Kistein, what have you noticed in the last week or two that you think we may have missed or that hasn't got enough attention?
Sure, most of it has already been mentioned. For me, on a personal note, this is a very triggering time because of the inequities that we see around police brutality and people of color. I particularly have been paying attention to the policies that are coming out in regards to policing and have been paying close attention to that. I've in the past very publicly stated that we need to be active participants, not only in healthcare, but also in our society to see a civic uprising where we're all coming together, or many of us are coming together and are really saying that we need humanism and we need everyone to be treated as equal human beings. That is incredibly refreshing and just interested to see where this goes.
Yeah, and you're in New York, is that right? Just check
I'm in
on
New
location.
York, yes, that's correct.
So you're at the epicenter of essentially both of these things. Kim, what have you noticed in the last week?
Well, I've been interested to see how we've gone from trusting our public health officials to ignoring them and now to demonizing them. I know in Ohio, our public health director resigned. Basically, she had armed protesters picketing her house. Kaiser Health News said that 27 public health officials have retired, resigned, or been fired in the last few weeks in 13 different states. So it's gotten really dangerous to be a public health official trying to protect us all.
Yeah, I mean, it's quasi nuts, right? The same thing happened in Orange County, and I don't know if you saw the video of the people explaining why they didn't want to wear masks and the Orange County supervisors. But I don't know. It's hard to imagine how you get to that place. But there are rational conversations about rates of lockdown and what have you. But not many of them were seen at that. I mean, to tell you. And when you're starting to talk about sending armed men out to protest,
I feel particularly bad for the Tulsa public health director who's saying all the right things, but he knows he's between a rock and a hard place.
Yeah, amazing. So I'll give you my quick one for the week, which is that. And I tend to harp on this in these sessions, is that how is the healthcare system reacting? And Sutter Health, which is our big local quasi-oligopoly health provider in Northern California here, has been appealing to not pay and hasn't paid the big settlement it made about 6 months ago, about 6 months ago, it got sued by the Attorney General of California and a bunch of its clients, a bunch of self-insured employers, for overcharging for years. And it agreed a settlement of about $500 million, which has now decided it can't afford to pay, even though it is, getting money from the government for early Medicare payments and also for relief from the CARES Act. It's decided it can't afford to pay that, even though it does. I think the latest tally had $6 billion in reserves. And I think we're really going to come to a moment relatively soon when we start thinking about, and we've discussed this a bit on the gang before, who's got the money in American healthcare and how should it be distributed, because what we've got now isn't going quite well. So with that as an intro, we raised a lot of points there, which I think we'll get to some in the discussion. I want to dive in a little bit and talk to Medell and Kistein about what they've been seeing as our guests this week. So Medell, I met you a few years back. You are like doing 17 things at once and can't be categorized, but I would say you're a visionary emergency room doc who also does a lot of work in a lot of different areas around social justice, and by the way, runs an IT company on the side. So I don't know which one of these is your side hustle, what's your day job, but tell us a little bit about what you do and a little bit about how you've been reacting and what you've actually been up to in the last few weeks.
Thank you, Matthew. So I am the founder and the CEO of Contour Health Solutions. And what that is a national advisory firm in which we provide clinical expertise and guidance to health technology companies and investors. And with a specific focus and expertise in serving under-resourced populations and how to reach those populations. In addition, I'm an assistant professor of emergency medicine at the David Geffen School of Medicine, and I'm a practicing emergency physician. And last but not least, this is the last one, Matthew, is that I'm the medical director of clinical effectiveness for UCLA Health, in which I'm responsible for value strategic planning, as well as, I would say, the quadruple aim. And so with all of the various different—
What do you do in the afternoon, sorry?
Play with my kids and my husband and watch reality TV show.
Yeah.
Unlike
So this has been a very challenging time in more ways than one, I think, for the country, for the world. And one of the things that I've been seeing definitely in all of my various different venues, whether it's directly from the healthcare world and preparing for COVID, dealing with COVID, then trying to figure out how do you reset the processes of an entire health system after dealing with COVID, but then managing COVID still at the same time. That with, of course, all of our social movement, as I mentioned, it is a time that one of the things we're seeing is that, especially I think in a lot of healthcare organizations, are trying to balance how we're delivering care and how we're delivering care to various different patient populations, and recognizing for the very first time, and I think there's many of us, and I know those of us on the line, we're very all aware of many of the health inequities that have actually existed in our country for not only decades, but generations. But now I think COVID just made sure that it was very much in the front of our society here in America, with seeing all the disparate rates of healthcare outcomes. And then, of course, with the murder of George Floyd, it also showed all the inequities in our justice system, inequities in many other areas of society, and how each one of us plays a role. And it's not isolated in one group or another in terms of healthcare or police, law enforcement, or education. It's actually rampant throughout our entire environment and society. And so what I'm seeing right now is our healthcare systems and others, but our healthcare system to the point where we're trying to address, make sure we're taking care of all populations, but also have to look to see what levels of bias that we may already have within our current structures, within our infrastructures in particular, that are contributing to the various health inequities that we continue to see? And are we also playing into other social inequities? So that's a very new dynamic that I don't think we've ever really had at the focus of healthcare, nor at the focus of our country. And so it's exciting because everyone's starting to talk about it. But then it's also to the point of truly, what do we do? Let's not do, for instance, performative actions, meaning let's just say there's a problem. We actually have to make sure that there's some action beneath the words as well.
So I can see Maggie wants to jump in here, but I would just say one thing, which is I've been sitting back and looking at a lot of these sort of statements you've seen from big corporations and hospitals and others. And I think what you said about performative actions is really key, because last week on the gang, we had Raj Agarwal, who's in strategy and innovation, but also, you know, a day-to-day surgeon at Jefferson in Philadelphia. And he said he met the president of his hospital, who said, "Why are you not wearing scrubs?" On the grounds that, you know, if he was wearing scrubs, he was operating and making them some money and getting them back sort of into the black. And if he was not wearing scrubs, he was wandering around doing his innovation work, and that's spending money. And, you know, even though Jefferson, one of the most advanced systems in America, is still someone that is focused on the bottom line. And I mentioned Sutter as well. So that tension is going to go on in healthcare. Meanwhile, we've got a lot of conversation about Kaiser and Aetna and United and others talking about spending money on housing and doing the sort of social determinants of health stuff. So anyway, Maggie, I think you wanted to come in on that. And Maggie's doing the Zoom CEO thing on mute. You have to unmute yourself. Everyone already saw the Zoom CEO did a conference call around his earnings session. He started the whole thing off on mute. So happens to the best of us.
Well, it's a good thing I didn't say much. What I'm curious, so in my work as an executive coach for physicians and administrators, I mean, I see everything is about the money. It's all about the money. And that's not why those of us in medicine went into medicine, I don't think. And so what I'm curious about, Medell, is how are you thinking to align incentives, right, which is, you know, we say we want quality, we say we want something, but you make more money if you do the stuff we say we don't want.
So that's a huge important question. And I've thought a lot about that. And my background is in quality and patient safety, and that's what I do on a day-to-day basis within my healthcare system and also in the company. And I think it's about aligning the incentives with the right outcomes. So right now, as we know, our healthcare system is based off of still all of those various different procedures, you know, whether it's surgery, whether it's interventional procedures, whatever that may be. But part of this has to be, and I think that's fine. I'm also a businesswoman. If you need to make money, that's fine. But the problem is when you put, Maggie, as you said, money over ensuring that appropriate equitable care is given to everyone and equitable outcomes are there. And so one idea, for instance, would be to really try to influence our federal agencies like CMS, instead of just giving reimbursement and value-based purchasing, for instance, on processes, why not take a look and say, okay, you will actually receive these reimbursements when your clinical outcomes amongst all patient populations by race, by gender, by sexual orientation, all of those different things are equal. Like that's what we care about, that people are actually having equitable outcomes versus you're just going through the process steps. So I think it does take a lot of thought and then shifting of our payment models in order to place it on value, in which it's value still, and I have a lot of thoughts, I still think there's other things, but most importantly, value between the various different patient groups so that we're not continuing to see disparate outcomes the way we've seen for so long.
I love that thought, and I think that's a great bridge over to talk to Kistein. Kistein, can you tell us a little bit about what you do at the Patient Orator and about, you know, some of the work you're doing, and then please weigh in on the thoughts about, you know, how do we think about outcomes as a whole experience or whatever you want to talk about in terms of patients.
Sure. So just to echo everything Medell just said, I fully co-sign. I filmed a movie and I started filming this movie in 2017 called or titled Dehumanizing Healthcare, because when I was on the front lines of healthcare, I saw that the healthcare system was failing the have-nots. And these were people of color, these were the chronically ill, and these were people who are of lower socioeconomic status. And as I traveled around the country and pitched the idea for Patient Orator, people looked at me as if I was crazy. And what I was essentially saying is, hello, we have a problem. We're spending too much money and we're not getting the outcomes that we need. People's voices are not being heard. And myself as a Black woman, in my encounter, having faced discrimination and bias in healthcare settings, recognize that the only way we're going to shift the paradigm is to really start listening to what patients are saying, but also listening to what the healthcare professionals are saying, the providers that are on the front lines, and the entire care team. So looking at how do you really address outcomes by fully incorporating care coordination. So at Patient Orator, we've built a tool and actively iterating and making sure that it's perfect. And what that tool does, it's a mobile application that helps patients, underserved patients particularly, narrate their storytelling so that when they are in clinical settings, that their voice are being heard, that they're speaking the same language as the clinician. And then on the other side to that is providing the access to those resources, so making it easy for people to gain those resources. And so we're really looking at health disparities by addressing the root causes of those issues. And our goal really is to help improve outcomes.
Lygeia, I heard a lot of words there that sound like words I've heard from you, so please weigh in on that.
Yeah, no, I love the spirit and the essence of what both of you are doing. And given that I work at a technology company right now, I am curious, I think from Medell in particular, since this is in your line of work, but really both of you, our company has done a lot of soul searching and conversations in the last couple of weeks and around this idea of wanting to not just make a pledge that says we will all do better and be more inclusive, but what can we do in a concrete way? And I would love a little bit of guidance for how you advise particularly developers of technologies that will be used by consumers as well as by doctors. How do you do that in a way that is inclusive, particularly of Black patients, really, at this point, but really inclusive in a broader sense too?
Sure. So
This
one
is
of
the free consulting part of the show that Lygeia is
not a problem.
You guys can send her a bill later.
So I'm going to bring up one scenario, which I think is a perfect example of how we have to be a little bit more forward thinking. So with the COVID crisis, our clinic shut down, our hospital scaled down, and we shifted very quickly towards telemedicine. And so for the first time, we saw this huge uptick in the use of all of our telemedicine services in order to conduct your standard day-to-day clinic visits, your standard day-to-day other evaluations. But one thing that we noticed when this occurred is that a lot of these new telehealth platforms did not include interpreter services. So when you're actually trying to reach out, so those patients that are not primary English speakers, we inadvertently completely isolated them during this time period, which likely has contributed to even worse health outcomes for them, because we did not think about the fact that not everybody speaks English. And if we are going to expand telemedicine services, let's make sure that there's some avenue to actually then plug in whatever that patient's preferred language is. Now, how could we have prevented that? I say that as a globally for we as the healthcare system, actually including more people that are sensitive to that, including more people that English may not be their first language, in which then people say like, oh, wait a second, this seems great for the majority, but what about for my grandmother that does not speak English? She only speaks Spanish, and she still normally is used to going into clinic and speaking with her providers in Spanish or using an interpreter machine. So that's one thing we're now starting to sort of grasp onto, that it's not just about being inclusive, but it's about providing really good care to all of our patients, regardless of their race, regardless of their language, what we're striving for even in in-person visits. So my advice is when you do develop technology, number one, think about the populations that you're trying to reach, both your patients as well as your physicians or other providers, and bring them to the table and make sure that you have representatives. And again, they're not ambassadors, but at least you have that voice, that inclusive voice of saying, this is what we're trying to do. How does this seem to you? What are your ideas? And one thing that I've learned in my experience with a lot of health technology companies is that it tends to be a small group of very smart people. However, one thing that does happen is that they're all of similar backgrounds. Okay, and that's not even just race and ethnicity, it's just experience. And it's sometimes hard for them to relate to others that may not be exactly like them. And so I say, and we have so many studies that are out there, the more diverse a group is when thinking about new solutions, the more successful that solution is going to be. So that's my one form of recommendation for developing new technology. Think broadly and not narrowly. One, your technology will be embraced more, but also it will increase your bottom line because you'll bring in more revenue more because you're hitting more people. But in order to do that, you yourself have to be inclusive of the different voices to make sure you're developing something that will hit the needs of your patients as well as providers.
Good one.
I will just add that, so I took some notes while you were speaking. I think that we really need to take a step back and understand racism in the United States from a historical standpoint. We cannot just go on about our daily lives as though this doesn't exist. Healthcare specifically, where we're touching patients, where we're caring for other human beings, we have to understand why there's mistrust within African-American communities or Latin American communities, whatever those community or populations may be. Once you understand from a historical standpoint why there's distrust, we have to put actions in place, like Medell just stated, to enhance cultural competency. So what I mean by that is basically have the systems in place where your workforce is going to embody the culture, not the culture, but more so the principles, the way in which the people and the population think. And that way, whatever solution you're creating will actually be more effective. In addition to that is if you can have diverse teams, outsource if you must. There's many ways in which you can build diverse teams. And in addition to that, I would say that look at ways in which you can partner with organizations in the community that's local to the market or local to the population that you're serving. And last but not least, your team should reflect the population that you're serving for.
It's even deeper than that, though. I mean, you know, how many drug protocols are based on white males, or how many treatment protocols are based on, you know, a small subset of population? I mean, we really have this embedded in our whole healthcare system that, you know, we're not really designing the healthcare system in terms of who it's treating. So until we get to those kind of roots, we're still going to be, you know, aiming the arrow in the wrong place.
Which goes back to my first point of we really need to understand the historical context of racism in medicine specifically, and really start paying attention to how we could bridge those gaps, because the providers may not even be aware that they have biases that they're carrying towards a certain patient population. And it's not realistic for any of us to think that any provider or all providers should just come in and be empathetic, because in people's individual lived experiences, they may not encounter people that are different from them. And so it then takes the system to take a step back and look at where they are, and then educate and empower them with the tools they need so they can effectively treat those patient populations.
I guess I would separate out sort of, I don't have the right words, but, you know, personal racism and sort of structural racism. You know, maybe very well-intentioned people with not a bias bone in their body, but if their bag of arrows is got structural racism built into it, they're still not going to be appropriately managing the healthcare that people are dealing with. So you got it. It's a very deep, broad problem.
Ian, can I grab you in here? Because I mean, you mentioned the MLK Martin Luther King board meeting you were at, and it sounds like a lot is appropriate for that environment for sure. I love to.
And I'm going to be a little sensitive in what share. In fact, Medell was the one who helped build the dashboards that we use for both quality monitoring and so forth. But I have permission for Elaine Batchelor, CEO, to talk about some of the general trends. But I think it's a perfect example. I mean, if you know the history of MLK, it was born out of the Watts riots. The old hospital, it was closed in the early 2000s for a bunch of reasons, both failure clinically and financially, and was been reborn with Medell's help in the last 5 years we've been open now. And we've actually ironically weathered the COVID storm relatively well, because we are, the way we operate is we're not doing elective hips and knees. We're looking after an underserved community and getting direct financial subsidy for that from 3 different levels of government. And there was this kind of a squeaky thing where we thought we were going to lose our supplementary funding for Medicaid, but that seems to have, that danger has passed. But I would say that all of these factors of structural racism and inequality are manifest in central LA, as Medell and all of you know. What was interesting in looking at the COVID-related data was, despite the fact that our typical census might be 50-50 African-American and Latino, given our location, it was disproportionately Latino in terms of COVID cases. And in fact, I was making the point that it was almost identical experience to what was found in the UCSF mission study, where there were 0 white people with a positive test, right? And that it was disproportionately people of color, particularly Latinos, and particularly in essential work where they couldn't be on Zoom meetings, but they had to take the early bus and be at work. And I just worry greatly that I think it's a positive thing for the country that we're having a national dialogue about race, but I echo all of my colleagues here saying we got to move beyond words to actions. And one thing I had been sort of working with some community groups, I was actually in Rochester, New York, who got very interesting arrangement of stakeholders, but and this is pre-COVID, I have been using a sort of a metaphor of inverse redlining, which is to say, redlining was a perfect racist example of denying access to capital for African-American communities in particular. and that we should be thinking about inversing that and creating disproportionate investment. Because I think Medell raised a great point. If we shoot for equal outcomes, which is a great goal, we've got to think about unequal investment, meaning more investment in underserved communities, not less. And so I just hope that we use the energy from this current movement to get both the political capital and the real financial will to change how we allocate resources to these underserved communities, and particularly with a goal of equality of outcome.
So I'd like to ask the group as a whole, unless Maggie, you want to jump in here, but how do we do that, and where do we start? Because, you know, if you go far enough back, and I've been shouted out on other forums for saying this, but, you know, if you go far enough back, we know, you know, that a lot of the work, and so George Halverson is now ex-Kaiser, is now out promoting this, but a lot of stuff happens in the previous, you know, your first -1 year to +2 years of life, and how do you get in to help kids, you know, with equal opportunities, and get them with better nutrition and better housing, and, you know, you get on the list. And sort of healthcare services are kind of late. I mean, they're part of it, but they're late in the list of things that matter. And yet it seems to me that we put all the money in healthcare, and we're now talking a little bit about redistributing money within healthcare. I mean, Medell, am I wrong, or is there something else that I should be talking about?
But you have to be careful when we define, you know, investments and outcomes, what we're going to measure. If what we want to do is measure the, you know, if the outcome is people surviving heart attacks, you make a certain kind of investment. If you want to make sure that people don't have heart attacks, you make a very different kind of investment. And I think we usually ask the wrong kind of question in healthcare. We ask the question about healthcare services and healthcare outcomes, when really we should be looking at broader health outcomes. And not many people in our health system are set up to take or make those kind of investments.
So Mel, say more about how you're going to do that.
Yes, and Kim, I completely agree with you. And that's why over the past, 5-8 years, the idea of social determinants of health have just kind of soared, because we know that you have your specific disease conditions that you want to make sure you're receiving the appropriate care so you do have a chance of survival. But why are people getting to that point to begin with? And so it does take a step back in terms of education, like the 6 pillars, traditional pillars of education, environment, your overall social context, which does include discrimination and racism, in which we know that there's studies that when people are subjected to racism or discrimination of some sorts, they have higher rates of cortisol in their system, which then can actually contribute to greater disease burden. And so that's clear. And so how do we actually shift more to be a prevention, which we really haven't focused on for anybody in this country, and making sure that we don't have those levels of racism and bias and exclusion that have continued to contribute to our health outcomes. But I don't think it's just a healthcare problem. This is a social problem. This is our country's problem. And we in healthcare are not going to be the only ones that are going to be able to fix this problem, especially when we're dealing with job security and housing security and all of these other areas. But historically, we have all stayed in our lane. And that's what my goal and my hope is, that now, even with all of the crises that have been here, but now everybody sees that they're even more that they're crises, that injustices go throughout the entire fabric of our country. And so if we want to make sure that our people of all backgrounds, but especially African Americans, I'm going to just call them as BIPOC, so Blacks, Indigenous, and people of color. So if we want to ensure that BIPOCs are all in a much better state and definitely have equal opportunity, equal health, equal social economic status, all of those things as other populations, then we do have to be a little bit more creative. We do have to do a lot more of bonding with our other colleagues outside of healthcare, but we also have to do our part of making sure that even some of our racist legislations out there, like for instance, one thing is the IMD legislation with even dealing with psychiatric hospitalizations. I highly encourage everyone to take a look at that legislation if you do not know about it. But what it does is that it excludes patients with Medicaid from actually being hospitalized in mental health organizations with 16 beds or greater. So those institutions will not receive reimbursement for Medicaid. And that's a problem, because that means that low-income populations are going without appropriate psychiatric care, and that is built within our legislation from 1965. So it takes us doing our own part of revealing any type of racist practices within our own institutions, within our own companies, and within the care that we deliver, and really being intentional about and acting on it. And then also how we can bridge ourselves with so many others in the other areas of our society as well. So this will be a marathon. It's not something that we're going to be able to fix over the next month or year. In fact, this has been going on for over 400 years. So it will definitely take a marathon to dismantle and rebuild.
So I don't want to jump in on that. I would reflect that a lot of the things you just said there, Medell, have got a legislative, a policy, and then a cultural and organizational change, which we're trying to make. And by the way, it's not just in healthcare. You mentioned housing. We're talking about transportation and energy as being something that is changing anyway. I mean, we're sending people to the moon and talking about electric autonomous vehicles, but we've got big changes. And a lot of this goes back. I mean, Ian mentioned the what's rights of the 60s, but a lot of this goes back to what happened in the 60s, 70s, and 80s. We kind of hollowed out the industrial base and didn't really replace it in any way. And that the inequality of that has gone forward, turbocharged 30, 40 years now. I'm just wondering if anybody sees the political appetite now, even with perhaps the Biden administration and maybe a Democratic sweep, maybe there's going to be one coming up, maybe not, to make some of these changes on so many levels that we need to talk about. I mean, we've gone back and forth on this a bit on the gang over the weeks. I think more people now are seeing the likelihood of, there's rumors today that Trump is not interested in fighting the election, is happy to go home or whatever, or maybe go to jail. Who knows? But do we see, is there an appetite in America for doing what you talked about?
I'm afraid not. I mean, we can't even get coalesced around defunding police and redefining public safety, and that's something that people can see on the videos. Defunding healthcare is something that we've not really thought about. We can't even support public health. So, if we think Medicare for all is hard, just imagine reimagining our healthcare system. It's longer than it's an ultra marathon. It's not even a marathon.
I'm a little bit more optimistic. I think the wave of sentiment and genuine support for the current protest is so not only massive but worldwide that it really does present an opportunity as an inflection point. I agree with you, Kim. We may miss on the opportunity, but I think if it turns into a significant turnout of younger voters and African-American voters and people of color in November, that sends a signal that we are rejecting the other path. I'll give you, I think one of the prime examples of structural racism is Medicaid expansion not happening in states in the South. I mean, there is no more blatant example than that. I mean, I think the Obama administration's Affordable Care Act was a step in the direction of social justice, but it's yet unfinished. So it requires the political momentum. The thing that worries me greatly is, that we may be looking at scenarios with a Biden administration where the intent is good, but we're in a $4 trillion hole in terms of deficit, and we won't have the resources or the appetite to do redistributive policies in that kind of environment. That's what worries me, is that we may have political will, but the resource side may not be there.
Lygeia, then Maggie. No, order now here.
I was going to go in some ways in a similar direction that Ian went in and say, I think obviously this is much bigger than healthcare. It's about policy at a very high level. And I think that although it doesn't sort of solve everything, I'm still bothered by the fact that about half of the country doesn't vote. So this whole idea of that seems like a pretty small action to make. It doesn't involve going out and lobbying personally or even being part of a march. If you feel something, get out there and show up and vote and, choose representatives who you think will better represent you than you're being represented right now if you disagree with what's going on. So that's, again, not that it's the silver bullet, but it seems getting out broader voter participation is one of the lower hanging fruits for change. And this sense that, I think so much about how hard people before us fought for the right to vote, particularly among particular groups, whether it's African Americans or women, people in general. My goodness, can we just exercise that one not small, but really momentous right?
Even if it means queuing up for 6 hours in Georgia or Wisconsin, that's been attacked as well. Maggie, unmute, please.
Fool me once, shame on you. Fool me twice, shame on me, and I'm fooled. So I have, I'd really like to think more positively about this. And I was in the Clinton administration years ago, and then I came back as a career person, worked at VA, and the policy piece, I don't know that there's even the will. And if you look at where all the money went that was supposed to stimulate the economy, look to see who got it, if we can even find out. And so I also, with Lygeia, like half the people vote. In Australia, it's over 90%. It's high in Italy. They have to vote. And so we don't, people say, well, what's one vote? Well, we learned what one vote was the last few elections. And I want to change a little bit, and I want to talk and ask that what can we do? And Kistein, you mentioned, actually doing something. What are those somethings to do?
I think that one thing that is not mentioned here is the power of the collective. And I think we shouldn't underestimate what our voices hold, the power that our voices hold, so to speak. And I think now that we're all activated, or seemingly we're more united for humanity in this way, that we can really create meaningful change, whether that means on a societal level or in healthcare. And I think it's just as simple as that, having activated, involved citizens.
I mean, there is a discussion about what percentage of the population has to be in the streets and what has to be activated to change stuff. And, you can go back to the last election where we saw basically lower turnout than historically you should have predicted amongst African Americans by people in three cities, Milwaukee, Philadelphia, and Detroit. And that's why there's a Trump presidency, not a Clinton presidency. Now, who knows if there was a Clinton presidency, how much things would have been different, but certainly some of the more, visual and sort of egregious things that have gone on in the last few years, even the attempt just in the last weeks to remove the ban, to remove the ban on discrimination against LGBT groups in healthcare, which came out of HHS, which is pretty unbelievable in 2020. And luckily the Supreme Court looks like it might reverse that eventually, because it reversed it on employment just this week. But I mean, I agree with you, Kistein. We've got an opportunity here. And I don't know, I'm always sort of somewhere between Ian and Kim about how cynical versus optimistic we should be about the chance to change stuff. But stuff does change eventually. But we have got so much, we talk about structural racism, we've got so much structure and infrastructure built around our current flows of money and power. Mm-hmm. And for the last 30, 40 years, they've been going kind of against this community direction. I mean, it's more out for yourself. And we have a bunch of people who seem to believe in that to the extent they'll A, go to a rally in an indoor enclosed space, or B, show up in a crowd with their AK-47 and start shooting people, which we've seen, this in the last week in New Mexico, where people who are friendlies of the police were there, literally shooting into the crowd.
I worry that, we may be actually closer about the will to change than we are about the vision of what to change to. I don't see any real leaders at the national level articulating a clear, understandable vision that people are going to rally towards. And so we have all these disparate solutions that people are offering, many of which are good, but there's no overarching vision that anybody's articulating to take the place of what we have now.
Well, I think you have some to your left and to your right on my screen. So, Medell, Kistein, tell me.
Yes. And one of the things that I've heard when we're all talking right now is voting, absolutely, being a collective, absolutely. But I think also unifying influence, power, and money in order to make sure that our representatives are doing what is important for the benefit of the country. And I say that in terms of, I think historically, sometimes we have voted as a country very superficially. Oftentimes, we may not look into a potential candidate's past in terms of their stance on racism. Are they racist? Are they misogynistic? Have they practiced xenophobic type activities? All of those different things, we haven't looked underneath the surface. And so therefore, they're then appointed and they're in these positions. And of course, why would they change based off of what their history has already shown us? And so I think there is a large amount of power in terms of making sure that the right agendas are forced for the right people to drive and hold our elected officials accountable, of saying, we put you in office, we actually added money to your campaign, and if you do not go forward with this agenda, which is important in these areas for justice, then of course your future term is going to be in jeopardy. And I just don't know if all of the people that have that power, and I can definitely say, I think even within the African-American community, we do have a lot of money and a lot of influence. And bringing that even together with many other groups of actually making sure that we are putting people in positions in order to benefit the greater good of the country, that's important. And then that accountability after that.
So can I ask a question?
Go
So,
on.
you know, we talk about the bringing together, and yet if you read George Lakoff's work or a number of people, Democrats are not so good at that because they tend to want to bring everybody in, and everybody comes in and there's not a whole lot of compromise. And so, you know, are we willing to give up something that we want in order to get some of what we want and let other people get some? And the answer, and I don't know the answer to that.
The other thing that worries me is that the people that voted for Trump or Jim Jordan or people like that, they knew exactly what they were voting for and who those people were. That's what they were voting for. So it goes back like Lygeia said, you need a lot of other people making their voices heard if you're going to not elect those kind of people.
No, I mean, look, we know this is true, right? Nobody can be in any doubt about what we've currently got in terms of the Trump administration, and whether Trump tweets that 95% of Republicans love him, whether it's 85 or 90%. There's no question that you have 51 or 52 cowed Senate, well, 51, right? Not Romney, cowed senators who voted against impeachment because they were scared, not because they personally like him. And to my mind, this is a really significant problem because the way that we're set up, back to my political science background, the way we're set up with the Electoral College and the states and the Senate and everything else, clearly you need a much bigger, and then you get down to voter turnout. Then you get down to really the tinfoil hat stuff, which may not be so tinfoil about, some of the voting manipulation we've seen around, closing voting machines. And also, God knows, there's a bunch of people who think that you actually got voting tallies mistotaled and manipulated by the Russians and God knows what. You go a long way down the fact to say you need to get this sort of big social movement. I don't know how big, it looks big, it looks united in the streets at the moment, but I don't know how big it is. And I mean, that's part of the issue. And the other thing that I think we all suffer from is that, we get our guy, quote unquote, our guy in, we get Obama in or Clinton in, and then most people who did that big effort go to sleep and assume it's all done. And then 2 years later, you lose the House or lose the Senate or what have you. So I want to twist this a little bit just for the last 5 minutes. Are there specific things, and come back to all of you who all have powers in healthcare, whether it's in tech or on the patient side or the physician side, are there specific things that healthcare leaders should be doing, either around the politics or in getting in front of waiting for CMS to come up with whatever the next plan for telemedicine is that could help move us along, whether it's around sort of the social determinants of health or the sort of the structural imbalance and racism that we've got there? Are there specific bite-sized pieces of advice that anyone wants to deliver out?
Go back to one of the most common problems people talk about. Healthcare leaders are the ones that are setting healthcare prices at unaffordable levels for people and then going after people in collections. if some
Pricing.
more healthcare organization said, we're not doing that anymore. This is our pricing structure. That's it. And, you know, we're not going to take people to collections if they can't do it. What's the argument against doing that? Money.
Well, I think another thing in that vein, I think another thing is to be transparent, because CEOs of large healthcares get a very small salary, and so when they give a percentage of their salary in, it ends up being about 1% of their total compensation, because they get a huge bonus, retirement funds, and I think, but what they report on is, this is my salary. So, and their salaries are going up and physician salaries are going down. And if you think of what the healthcare system is built on, it's the work of all the clinicians and the tests they order.
And one other additional thing is, especially to move the needle even before our government decides to take action, is we can do it in our own institutions. We have all the data, and we can just monitor what our outcomes are and commit to the fact that our outcomes for each patient group will be equal. And we're going to put forth the efforts to do so. So that's something very simple that every single healthcare organization can start today.
Yeah, I echo that. I totally agree with that. But I also think a starting point for any individual leader is to be listening to the communities of color, either both their patients and their workforce and their colleagues, and ask the questions of why not have diversity in leadership that mirrors the community we serve, and to just be kind of forceful in saying that's what our expectation is going forward. And I think those are actions that boards can take and that leadership can take.
You're here, Ian. I love that.
Lygeia, you guys are both you're one of the other patient advocates here. Well, everyone is, but you two particularly.
When we think about kind of social justice generally, there's this spirit of kind of uprising against things that are clearly wrong, that are often hidden and we don't talk about. And in no way to belittle or take away from the importance of Black Lives Matter and discussions about race, but instead to sort of take that energy and transfer it over to healthcare. I feel like many patients have no idea what a mess this system is, and thinking of ourselves collectively as patients, as people who do have power, particularly in cases where there is some transparency, to vote with our feet, particularly now that more care is virtual. You may have different options for care. Start demanding and talking about what's wrong with the system and not take it anymore, because it's horrible. Why should we put up with this?
Kistein.
I think every healthcare system should be looking at how they can treat people as human beings. Everyone that walks into their front doors, to the people that work in their institution. And I think that's the most basic thing that you can do, going back to the point of data. Collect data, start measuring, seeing where you're failing these patients or your employees, and try to address things head on from there on.
All right, we have just we have a few minutes left. Does someone want to jump in? Did I miss someone? Okay, we have just a few minutes left, and so I want to do what I always do at the end of the gang. It's been an amazing conversation. So I'm going to ask you all for a quick soundbite here on what you expect or maybe hope for the next couple of weeks as things are moving fast. What do you expect to see, or what would you like to see in the next few weeks? I'll start with you, Kim.
Well, it's not what I hope to see, but I'm very curious to see what the outcomes of the Tulsa rally are. I mean, how quickly will it be before those cases start showing up?
Right. Maggie.
I'd like to see what that is too, where the spikes are or the continuation. I'm also curious about, for many of the peaceful protests, we haven't really seen any spikes. Now, most of the people have worn masks. I'd actually like to see more peaceful protests around, just like the ones that were tear gassed by Trump, but be peaceful and not get tear gassed.
Yeah, and just on that note, before I go around the rest of the horn, I had a conversation with Rahul Dubey. He was the guy in DC. He used to work for AHIP, by the way. He's the one who opened up his house and had 75 protesters came in. I had a conversation with him and one of our other colleagues, Alison Martin, who's on THCB from last week. Well worth a look, and very, very interesting indeed. Lygeia.
It's incredibly easy to be discouraged and overwhelmed at this point. And so I hope to see and to contribute to shining a light on the sparks of hope.
Ian.
Well, I would just say watch for self-insured employers who I think will start to make more noise in the next couple of weeks about them not just simply restarting the game, as we call it, the way it's always been played. I look out for that.
Yeah, some noise from them. Medell.
We've seen two significant rulings from our Supreme Court. One first with our anti-discrimination ruling against LGBTQ, and then today with the DACA ruling. My hopes and my expectations is that we continue to see bold action within our country based off of those things.
Yeah, and I think that pretty damn surprising. Both of those ones, especially the majority against the LGBT discrimination. Having said that, if you read one of the cases, the one about the school teacher in Oregon, it's horrendous. And by the way, discrimination was in Portland. It wasn't in some redneck part of the country. Amazing. Kistein.
I would love to see more investment in Black and Brown communities. I would love to see policy be placed to protect vulnerable populations and underserved populations. And last but not least, make healthcare accessible for everyone.
Yeah, whether we're in the next week or two, I'm not quite sure. But I think what I'd end up with commenting, and you know, it's been my rant for a while, is that while we're making these payments and these investments or the CARES Act, we have a huge flow of money coming out of CMS, and more and more, I was getting articles in the New York Times and elsewhere, people focused on what are the large healthcare institutions in this country doing. You know, it does come down to is that if you're Mayo Clinic and you have $10 billion in your endowment, and you've got Martin Luther King in LA, in South Central LA, servicing an incredibly underserved population, you know, who've got all these needs. How do you balance that? And orthogonally, the other part of my 2x2 on that is sort of rich poor is sort of thinking for the profession of physicians and the clinicians. How do you start to think about, to Kistein's point, what is going on with the people who are not just coming into your, maybe they're not coming into your waiting room at all anymore, maybe they're staying at home. What's their life like? And Ian, you were on a Bob Wachters great podcast. Everyone should listen to it. Bob did with you and Abraham Verghese and some others. And I was actually out running while I was listening to it, and I was half listening and sort of yelling in appreciation and half sort of shouting, wanting to punch somebody about some of the stuff I heard. And one of them was when Abraham Verghese said, well, you know, it's amazing, you know, the guy who's kind of the anti-technology and healthcare guy to some extent. He said, I've been doing this telehealth and it's amazing. I can see into their room and see what's really going on in their lives. And it's been amazing. And maybe in the future I could send, you know, we could send like a box with equipment to their house, maybe in 5 years. And I'm going, all of this stuff has been around for years and years and years, and we can do it. And we should have been focusing and getting, you know, influencers like that to focus on what's going on in those patients' lives rather than what's going on in my exam room. And I think some combination, this is my now me pontificating well past what I should be doing, but some combination of figuring out how do we get the technology and the structure into doing all the things we talked about, live translations, you know, live remote monitoring, understanding what's going on in those people's lives into our healthcare system, and how do we balance the way we spend money. We've got that conversation, I think, is, you know, has got to start up. So apologies for doing a whole bit of ranting at the end there, but we've now come to the end of our time. This has been an amazing conversation with the THCB Gang for today, the 18th of June, my mother's birthday. So perhaps, unfortunately, she's long past, but perhaps they'll be inspired a bit of that. I really want to thank my guests, Kistein Monkhouse, Patient Orator from New York City, Medell Briggs, multi-virtuoso of all things to do with clinical care and technology and much more, down from Los Angeles, and regulars, Kim Bellard, Ian Morrison, Lygeia, Riccardi, and Maggi Cary. It's been a great THCB Gang. Really enjoyed talking with you all. We will be back, same back time, same back channel next week, 1 p.m. Pacific, 4 p.m. Eastern, next Thursday.